in cardiology, we have two types of patients. One group are patients with stable angina, and at the other end of the spectrum are patients with unstable angina or acute coronary syndrome. Now, what is stable angina? Stable angina means that the person concerned has chest pain, which comes on with exercise like walking maybe 100 yards, 200 yards, or climbing up a flight of stairs. The pain stops when the person stops walking and rests, or the person takes a nitroglycerin tablet. All right, so that is stable angina, and it is predictable, whereas unstable angina is chest pain which is coming on at rest, which is more severe, more frequent, and which can be prolonged, which does not stop. So first we will talk about patients with stable angina. How do we treat such patients? Now, the best source is this big randomized trial called the ischemia trial, which was published more than a decade back in the New England Journal of Medicine. The ischemia trial, which included patients from more than 30 countries, from more than 300 centers. It included more than 5,100 patients with stable angina. And importantly, these patients had objective evidence of severe ischemia, or at least moderate ischemia, which was assessed either by a stress nuclear test or a stress MRI test, or even an echocardiogram, that is a stress echocardiogram, which showed that at least 3 segments of the heart were not working properly. Now, we have patients with stable angina with the objective evidence of severe ischemia, and these are more than 5,000 patients. We divide them into 2 groups. The first group gets immediate invasive treatment, that is angiography, and if feasible, angioplasty with stenting or even bypass surgery. The second group, the control group, is the one which gets only medical treatment. Now, these patients were followed for a median of 3 years, and what was seen was that there was no difference in the clinical outcomes. In simple English, whether you had an invasive strategy of immediate angiography accompanied by stenting if required, or whether you were kept on optimal medical treatment, your chances of dying were the same, your chances of even having a heart attack were the same in a follow-up of more than 3 years. Of course, the researchers took a composite endpoint of death, myocardial infarction, hospital admission for unstable angina, heart failure, and cardiac arrest. But the number of deaths in the invasive strategy group were 145 as opposed to 144 in the medically treated group. So clearly there was no difference, absolutely no difference in the number of deaths whether you underwent medical therapy or you underwent angioplasty with stenting if you had stable angina. Now, importantly, of these more than 5,000 patients, 42% had diabetes, 73% had high blood pressure, and more than 70% were smokers. The median age was about 64 years, and 75% of the patients included in this study, the ischemia trial, were men, 25% were women. So the take-home message is clear. If you have stable angina, which is brought about by exercise, by climbing up a flight or 2 flights of stairs, or is brought up by cold weather, and if it recedes or settles down by stopping or resting or taking a tablet of sublingual sorbitrate, then whether you take medical therapy, optimal medical therapy, or whether you undergo angiography accompanied by stenting if required, the clinical outcomes remain the same. So that is a very important thing for you to understand. Now we take the other group, that is patients with unstable angina or an acute heart attack. Here we have the latest Lancet. I have already touched upon this meta-analysis, which included more than 8,800 patients with an acute heart attack. So this is a huge meta-analysis published in the current issue of the Lancet. I will provide you the links of both the ischemia trial and this study, the meta-analysis, in which the median age again was about 63 to 64 years, 75% were males, 87% of these patients had what is called an ST elevation myocardial infarction, and about 12 to 13% of the patients had a non-ST elevation myocardial infarction. For your benefit and for your understanding, we are talking about patients with heart attacks, right? And here, what they did was that they did what is called a complete treatment or complete revascularization, as opposed to incomplete treatment or incomplete revascularization. Now remember, the ideal treatment, the scientific treatment for a heart attack is angioplasty with stenting. When you have a heart attack, there is one vessel which is blocked, which is either completely blocked, that is 100% blocked, or suboptimally blocked, that is almost 90-95% blocked, and this artery is called the culprit vessel or the culprit artery. Apart from this, there are two more arteries, and these are called non-culprit vessels. So when you opt for a complete treatment therapy or complete revascularization, we are talking about tackling the culprit vessel along with the non-culprit vessels. So that is a complete treatment. Now this could be done in the same setting, or it could be done while the patient is in the hospital, or it can be done within a fortnight or 3 weeks. As opposed to this, we have the other group, which has only the culprit vessel being treated with angioplasty and stenting. So what happens now? In this meta-analysis of 6 randomized studies, it was found that complete revascularization significantly reduced mortality from 4.6% to 3.6%, and also heart attacks from 8% to 6%. So the message here is clear that in the event of a heart attack, and this is seen in about 25 to 30% of patients, if more than the culprit vessel there is disease, that is, the other two vessels are also blocked, maybe 50%, maybe 60%, maybe 100%, then the ideal strategy would be to tackle them also in the same setting or very close to the same setting. And this meta-analysis was preceded by another big trial, which was published in 2013 in the New England Journal of Medicine, called the PRAMI trial. This was a British trial. It was a smaller trial that included about 465 patients with an acute heart attack, and these were divided into a complete treatment therapy or non-culprit or only a culprit vessel therapy. And once again, it was found that there was a significant decrease, a relative decrease of 65% in mortality and heart attacks. So now we have a strong base on which to make our claim that in a patient with a heart attack, and in the event that you have a vessel blocked apart from the culprit vessel, then the best treatment choice is a complete treatment strategy or complete revascularization. Now this meta-analysis is very important as far as I am concerned, because in the world, even today, the number one killer is heart attack. In fact, the number of cardiovascular deaths about 2 years back in India were about 282 per 100,000 as opposed to the global average of 233 per 100,000. Again, in simple words, more than 7 million people die of a heart attack in a year. That is, more than 70 lakh die of a heart attack in the world in a year. And probably more than 50% of these people are in India, because unfortunately, India is the hub for diabetes and also for cardiovascular diseases. Now, the study is against the backdrop of the air which we breathe in Delhi, which you will all agree is very healthy, which is very pure. We have an AQI today of more than 300, and we know that the upper limit is only 50. We also know that the WHO states very clearly that the upper limit for a PM of 2.5 is 5 micrograms per cubic meter, whereas the annual figure in India is more than 100 micrograms per cubic meter. Of course, our experts say that the level should be 50 micrograms per cubic meter, but the fact remains that we have a lot of pollutants in our air, and which will definitely contribute to more heart attacks, contribute to more strokes. So, ladies and gentlemen, let me finish by emphasizing that in the event of stable angina, there is no need to undergo an angiography followed by stenting or a bypass surgery. But if one has a heart attack, and if more than the culprit vessel is involved, if the other arteries are involved, then it would be a wise idea to get a complete treatment done. Now, the benefits of the complete therapy in this meta-analysis, which is published in the current issue of the Lancet, was seen regardless of the age, that is below 60 or above 60, regardless of sex, that is it helped both women and men, regardless of the number of non-culprit vessels involved, whether it was a single non-culprit vessel or whether both non-culprit vessels were involved. And even it did not matter whether the lesion in the non-culprit vessel was proximal or in the mid area of the vessel. And also it did not matter whether the operator assessed the non-culprit vessel angiographically or whether physiologically. The important thing is that you should treat the non-culprit vessels either in the same setting or as quickly as possible. Thank you very much.